Welcome everybody today to today's Health Economics Forum. By way of short introduction, I saw the most amazing fact yesterday brought forward by some Dutch scientists to say that if we kiss somebody, we share about 80 million bugs between us. So that's rather depressing for me because I like kissing people. I also heard that some hospitals are now on black alert already with too many patients coming through needing to be treated, and we haven't even got through to the worst of the winter weather. I also found out that it's obviously 90,000 more people waiting for an op this year than a year ago. Sounds very depressing. 24% of patients can't get a GP on the phone. It all seems very bleak, as always. But we're here today to maybe talk about some good news stories, perhaps, in innovation and how the private sector can work with the NHS. So I'm going to hand over to my colleague Matthew Locke, who's going to take charge of the first debate.
Right, we've put this together in response to Mr. Stevens' NHS 5-year blueprint, and one of the pillars of that, as he put it, is behavioural interventions in trying to communicate and lobby for a healthier population. We've got some interesting academics and management consultants and consultants from the NHS here to talk about that. So I want to start by asking Professor Mireille Joff-Bonnet. And I wanted to ask you, can you just talk a bit about the scale of the problem in figures in terms of obesity and other addictions, and what it's costing the NHS?
So the latest estimates are that obesity is costing about 5.2 billion in direct costs, where smoking and alcohol-related problems are lower, and each are about 3. There are different estimates. I found a very wide range, but they would be between about 3.3 billion each. Meaning the obesity problem is the really depressing one at the moment. Nevertheless, I've been reading about this in preparation for today. The scale of the problem in the UK has reached, it's not growing at the same pace in the last 5 years since 2008. So it is bad, but it's not getting as bad as we thought at the same rate as before. So. And
how does it compare with other countries in Europe? Do we have more of a problem than the Spanish?
I'll tell you, it's different. Okay, so obesity, the problem, how we look at the problem is how many children are obese. And with that, we are not doing very well because there are many obese children, but we are not the worst. So in Spain, the worst countries in the world are the United States, Mexico, Hungary for some reason, and I think New Zealand are ahead of us, and even Australia. We were in a worse situation before. We now are number 7 worst, and we were 5. In this sense, there are countries that are worse, but we are not the worst case scenario. So with respect to other countries, there are many more countries in Europe that are doing much better. And it's related, for instance, to exercise in children, where Austria is first. There's Austria, Spain, and these countries have a much higher activity. Maybe, and I was thinking it's related to the weather, but it's not, because Austria is quite a cold country. And I think the government and private initiatives can make, and the education system could contribute to children to be much more active, watch less TV, and be fitter. At the moment, we are not there. So there's a lot of work to do.
So that's a large amount of money, though, isn't it?
Yes.
And on top of that, there are indirect costs as well, which people would make it much bigger.
The indirect costs are huge. It's a bit controversial from the economic point of view to calculate the indirect costs, because there are many ways to do it. I don't know, Rebecca knows this. And sometimes we don't agree with the estimates. But in any case, obesity creates not only comorbidities like diabetes and circulatory problems and etc., but also there's absenteeism and lost productivity. And this is what makes the number go up to 15 billion lost in the UK.
15 billion lost
in indirect costs
each year?
Yes.
Right, which is colossal, where people are talking about
because you are projecting over the lifetimes of those that have obesity.
Right.
And it's much bigger, in fact, than smoking and alcohol-related problems.
So, in terms of behavioural interventions, can you talk about any of the interventions which actually work, are shown to be working with parts of the health service?
Okay, so we were talking about, there is a lot of talk now about brief interventions at the GP level. These work, but the problem with us is that they may work, but to maintain them over time, it's a different issue. So different countries have tried different, like syntaxes, right? Syntaxes, I think Mexico, was taxing overly dense caloric food with a tax, and that seems to work because Mexico is one of the worst countries in the world. That worked. Then I think it's other countries like Denmark, they are taxing saturated fat foods, and the demand goes down. But the problem with that is that when you tax some kinds of food, it's very regressive in the sense that people that are poorer end up paying much more of it than the others.
Matthew, you might bring Myron in here because he was telling me some interesting things about diabetes, which is affected by obesity, and his ideas on how we can tackle this. Just briefly.
Obesity is a massive problem, and I think it's got to be tackled head on. I think the first thing to tell patients is loud and clear, like you have on cigarette packets, that cigarette kills, tobacco kills, obesity kills. There's no doubt about it. Your life expectancy, if you're obese, is reduced very significantly. Obviously because of things like diabetes, hypertension. I think the other thing about obesity is that it is massively antisocial. It is massively antisocial. Just being next to someone sitting next to somebody on the tube, for example, or on a plane, is massively antisocial. The fact that these people use far more public services, welfare services, than healthy people, that's massively antisocial.
But what about, Myron, if I can come in there and say, how do you tackle this problem? Should it be done at the primary care GP level? Do we need more nurse training to help GPs with interventions? What do you think, Professor?
This is a question that's around, but I'm not. Brief interventions are quite easily executed. I don't think you need a massive training to provide information about the bad effects of obesity. It does work for smoking, and it sort of works for alcohol. So I was saying, I think that's where we are going. There are other ways that are available to the policymakers, like labeling properly. That's a very important thing. And then this syntax, and incentivate it in a constructive way. Another problem there is that there are some campaigns that have been criticized because they stigmatize obese people for some reason, exactly.
So it has to be done with sensibility and care.
Yes. Because they create a negative.
Myron was telling me he had a brilliant idea to tackle it, though, at GP surgeries. Do you want to explain?
About diabetes?
Yes.
Well, all I was suggesting is that the problem with GP care is that 2/3 of care in general practice is to look after patients with chronic illnesses, for example, asthma, diabetes, hypertension. And my suggestion was that because the technology has moved on so much, little of it is available in general practice. My idea was that we should bring clinical nurse specialists into general practice and link them to hospitals, integrate the two components of the health service, in other words, the monolithic structure, which we call the hospital service, and the monolithic structure that we call the general practice, and have nurses linked to hospitals but practice in general practice. And they look after the diabetic patients, for example. They look after the patients with asthma rather than the GPs. They're super skilled and they're disease-specific clinical nurse specialists. And
so Myron, this is looking at changing the GP model slightly to make it bigger, more inclusive.
That's got to be the way forward. There's got to be a massive change of the way primary care is given.
And Wolfgang, can I bring you in from Mercer just to talk about what role do employers running businesses have in managing things like the obesity crisis and obviously smoking, alcohol abuse? What's the
Employers
role?
have a massive role to play when you consider that any impact on health translates into productivity gains for the organization. So it is not just an altruistic motive that would motivate an employer to get involved. It is about presenteeism, which is linked to productivity. It's about absenteeism. It's also about staff turnover. When you compare that, of course, also to the huge healthcare costs that American companies have to pay, then you also have a direct return on investment on your services to the health of your employees. In the US, for instance, the share for healthcare for an employer on average is about 10% of payroll. That's very significant. So the business case is easily made in the US. Whereas in Europe, we tend to see on average about 3.9% of payroll, which is still a significant cost. But when you interview HR directors in Europe, they would argue that health and well-being initiatives pay off because of productivity gains and reduced absenteeism. And then perhaps on third or fourth position, it's about premium containment that they are also interested in Europe. So an employer has a significant role to play there. And that also has an impact on the NHS, because when you think of measures that you can take in the workplace, it's like health and well-being days, or health screening, or know your numbers, or health risk assessments, you get usually a fairly high take-up. And in most cases, if it's well promoted, a significantly higher take-up than when the NHS goes out with a campaign of preventative medicine.
So just to bring Rebecca McDonald in here, are these things about communication and education?
Providing people with information is going to be very important. And I think that is something that, as we've said, that GPs could do or nurses could do in these brief interventions. And that could come from the companies as well. But I think there's a lot of research that suggests that it's not always a lack of information that causes people to make bad choices over their own health. There are other things. So you could imagine somebody that's got complete information, that understands that they would like to be healthy, they would like to exercise, and they would like to eat well. But they struggle to follow through on those plans. So I might intend to go to the gym, but I'll go next week. Gets to next week and I choose not to go. And it's this sort of lack of commitment to health behaviours that I think could be an area that could be tackled quite successfully, possibly even within these brief interventions. But if we look beyond just giving people information and start to look at more creative ways to get them to change their behaviour, that's ideal.
Wolfgang, can you give any examples of sort of more creative things that perhaps employers have done to get people to sort of stick with exercise regimes? I mean, I'm thinking something that the Nudge Unit from the government was working with, I think, Melbourne government in Australia, and they got Grand Central Station, they repainted the stairs. So instead of everybody using the escalator at rush hour, suddenly everybody was excited by the colour of the stairs. So a lot more people were using the stairs. And it seems rather obvious and perhaps trivial, but it's working.
Yeah, behavior change is clearly the holy grail of tackling the various epidemics that we are facing that are linked to lifestyle. And I think the example that you alluded to is a good one, of course. It's a very simple tactical solution that we tell organizations that if you make the staircase more attractive, it's the first thing is to have a properly lit staircase so that you comply with health and safety messages here as well. And then make it even more attractive. I have seen organizations who have art in the staircase and encourage people to sort of use that as a short, brisk exercise. But it's also about making behavior change sustainable. And for that purpose, we need to harness the technological revolution. And what we see, of course, there is a big use of workplace challenge platforms. So it's an opportunity to use gamification principles to allow individuals to where, if they are so inclined, to compete with each other in teams. So you enhance teamwork, which is another big element of workplace satisfaction. And you say, for instance, okay, you wear a pedometer, and the first group that reaches Paris gets a free weekend in Paris. That is relatively creative, but it's not novel anymore. I have seen other approaches. For instance, where you want to promote an EAP, employee assistance programs are notoriously underused in most countries. But if you make them more relevant to staff, and you find, for instance, engineers going out and have the number of the EAP stitched into their uniforms, these are very practical, tactical solutions. Asymmetrically subsidizing healthy food in canteens and so forth.
Maria, can I bring you in?
Yeah, I wanted to comment two things about innovation. One thing that we know works for substance abuse addicts is the contingency management and providing lotteries, participating in lotteries for a prize, even if the probability is very, very small. We know from prospect theory that we tend to oversize probabilities that small, so only the thought that you may win something reduces cocaine and heroin abuse effectively. I'm thinking that in the sense that you were saying before that we need maybe training nurses and GPs or changing the GP surgeries in a way that allows more follow-on obese people, and introducing this kind of incentives could work because it increases their commitment and participation.
But Myron, I wanted to bring you in back again, because do you think that the government should be tougher with the supermarkets and other measures so that they really do insist that the traffic light system should be on foods, or they really do insist that there shouldn't be so many hamburger joints all over the place?
This is not something that I'm an expert on, and I don't know the answer to that question, but listening to my colleagues making these very, very valid points, I still think that it's got to come back to self-discipline. And it's got to be to do with explaining to people the massive dangers of obesity, and if they want to carry on with it, that's fine. They'll finish up, their lives will be shorter, they're more likely to finish up in a wheelchair, and they're more likely to be chronically ill for the last 10 or 20 years of their life. If that's what they want, carry on.
But Myron, how much of this is down to, if you like, culture within the NHS and our GP clinics to actually, if you like, encourage people to take charge of the healthcare journey? And again, this is what Mr. Stevens was talking about, the patient-centred healthcare journey. Well, what does that mean?
It means stop running a nanny state. Stop. Why does the government have to take responsibility for people's obesity? It's up to patients. The government responsibility to tell the patients or the populace loud and clear what the dangers are and stress them. And as we say when you're learning anatomy, the cost of learning is eternal repetition. Just say it and say it again and say it in different forms and accentuate it and repeat it until eventually the penny drops and people will realise they've got to take care of themselves.
But if I put pressure on you, Myron, to launch a campaign to make healthy eating sexy, I mean, I much prefer chocolate to celery sticks. What would you do? How would you? I mean, you've got the terrifying message, and that works with a certain proportion of the population. But then they, a few days later, they're not so terrified. How do you make healthy eating sexy?
I don't know. Do you know what I find with weight loss and talking to people who've lost weight is that once they start losing weight, once they go to make things unpleasant for themselves, like doing exercise to lose weight, and they start losing weight, then weight loss becomes kind of addictive, and they love doing it. I was out at the chap last night, and all he's done is stopped eating bread, and he's stopped eating sweets, and he's lost a torrential amount of weight. He grabbed some seconds of something else that was going around the table last night. He said, "Oh, that's all right, as long as I don't eat bread and I don't eat sweets. You can have your own limits, your own discipline, but you've just got to do it."
So, I mean, Rebecca, is it actually introducing a competitive element? Is it making it fun? I mean, it's dreadful being a Puritan and saying you can't have chocolate and you can't have the donut.
Well, what's interesting, I think, about what was just said is it picks up on some fundamentals of the way that we know that people make choices and go about their day-to-day lives. So rules of thumb and heuristics are much easier for people to handle than long-term complicated goals. So while I might have a long-term goal to be slim and healthy, it might be easier for me to just use the rule of thumb, like you said, I won't eat sweets, and that, will in the long run work out for me. The other thing that's interesting is habit has been identified as one of the main drivers of health choices. It sounds kind of obvious. The habits that we get into are really, really hard to break. And one thing that I think researchers are nervous about suggesting is financial incentives for behaviour change. Because you could say, well, a short-term financial incentive to attend the gym, what's going to happen, once the financial incentive ends, do people stop turning up? Well, actually, if you can turn something into a habit through a short-term financial intervention, then in some cases, especially the exercise case, it's been shown that these benefits do continue after that. So it's kind of harnessing these heuristics, these habits, and that seems to be one way that you can help to make the penny drop more quickly alongside the information.
I would like to echo that, because I think I only partly agree with what was said earlier about you have to appeal to people's self-discipline, because self-discipline is different from forming habits or rituals. If Thursday is always my gym day, I have to leave work on time, my personal trainer is waiting, it becomes a habit. It's very different from saying, when I come home, I will consider whether I can muster the self-discipline of going to the gym, and I will ultimately be too tired to do that, and I will give in. So I think it's appealing to intrinsic motivation of employees and people that is more successful. And another point as well is when you are appealing to intrinsic motivation, you sort of empower them, and it is not a nanny state, because you are convincing people, persuading them to do the right thing, and you can best reward them if they find a way of designing their healthy habits in such a way that they don't have just a long-term goal that they are aspiring to, but also some short-term reward, even if it's a hedonistic one. But we know from behavioral science and behavioral economics that people cannot sustain behavior change if it's only aimed at a reward in the distant future. There has to be a distant future reward and a proximate one that is more successful than.
Matthew, I'm wondering whether you want to just sum up on that debate, maybe with the last comment, and we might move on to innovation as Declan hasn't arrived.
Yes, we could move on to innovation. I think that's very interesting, talking about habits versus self-discipline, and also, very importantly, the role of, if you like, enlarged GP surgeries. That's a change in the model. Maybe we can come back to that later, because I think a lot of the sort of nurses and assistants in healthcare practices are underused. They're not given enough responsibility. Myron would probably agree with that. But Professor Geoffrey Bonnet, do you want to sort of sum up by just, again, we've got this colossal financial problem, but, is there light at the end of the tunnel? Do you think people, whether it's companies and it's NHS trusts, individuals, are people starting to see behavioural change as a way of improving things?
I think there is light, but everybody has to be involved, and I agree with all the members in the panel that we have to change the primary care system so people feel more committed to their changes. We have to introduce all these incentives that we know can change habits and can reward the change of habits in a sustainable way in the long run. And I think there is light at the end of the tunnel, but we have to provide a lot of information, we have to change things. Firms have to see that they have to provide maybe showers in their buildings so people can come running or riding. There are many things that can be done that are not being done at all, and we have to make children do more exercise. There are many things that have to be done.
So schools have a role as much as
And I wanted to mention that the state cares so much about the obesity because we all pay with tax money the cost of obesity, where alcohol and smoking, they pay a lot of taxes and they pay their way. For obesity, it is not really, because there's no sin tax, there's no tax on trans fats and sweets. So that's why the state is trying to see what we can do.
That's a very good point. Well, thank you very much to all four of you, and we'll move on to the next panel.
So if we just start this panel debate on innovation, can I just get the three of you just to go along from Derek, introduce and say who you are before we start the discussion?
I'm Derek Wyatt and I chair the southeast version of an NHS intellectual property hub.
I'm John Giles. I'm a radiologist in the NHS but also medical director of Benenden Hospital and Benenden Healthcare.
And I'm Doug Wright, medical director at Aviva Health and prior to that a GP.
So Derek, can we start with you because you're very much at the centre of this huge change and crossover. Tell us a little bit about what the landscape might look like, whether these hubs are going to disappear altogether or are they going to be reinvented?
Well, we've had, we were a model that was based basically on the regional development agencies and we were seen as the sort of health innovators and we were funded centrally by the health service. We think collectively the 9 have created about £100 million worth of savings. But it's very hard to get a rate of investment or a rate of return information on that. But inevitably, even though they're closing down, my sense is in due course they'll be reinvented. I wouldn't have done them the way that they were done. They were, as it were, let out rather like the RDAs, without any central control or any central sort of holding. I would have done a hub and spoke model. Because now what you've got is you've got 9 centres with intellectual property with some funding still in their banks. But actually, where does that intellectual property go? If there had been a hub, it could have been seen to be in the hub, owned by the NHS nationally. And then actually you could have put next to that maybe an investment bank, a private equity fund, a crowdsourcing. You know, you could have lined up a much more sophisticated financial model.
So how would you like to see innovation progress? I mean, you've explained very well the situation. What is the biggest area of innovation, Derek, that really has to be pushed forward?
Well, the government has created the academic health and science networks in a kind of replacement for the hubs. They're really hoping that most innovation in health will come probably out of a university. Probably. I mean, of which Imperial is, I would say, the leader. I mean, in the same way that Stanford is in America. Now, with Stanford, to give you their model, I mean, they didn't actually hold on to any intellectual property. So if you were a doctor, surgeon, innovator, whatever, you had 100%. That's no longer possible. There's now a 50-50 break between the university. I mean, and for instance, I mean, Google, they didn't hold anything, nor did they hold anything on the Sun Microsystems or in Hewlett-Packard or, you know, whatever I want to say. But intellectual property is the key to all of this, and funding. Now, the problem with health is it takes rather a long time to get from the innovation stage to the mature stage of flotation. That could be a journey of 5 to 7 years. And no government gets any votes for that. And no trust has got the chance of looking further than really the end of the winter crisis in flu. And, you know, if you came and knock on the door of the chief and say, by the way, I've got this idea for innovation, could you just let me have £100,000? Bless. Now, that isn't going to happen. And it's trying to change that behavioural circumstance. And that is difficult because the innovation fund that's just launched on the 1st of May is £5 million per region. It's just peanuts. If you compare that with what was the Technology Strategy Board, where they had millions and millions of pounds, but that was funded out of BIS. And I am wondering whether there should be a kind of an alliance between BIS and NHS when we're talking about innovation in health. So that I'm being run ragged by the government, but actually I'm running them ragged too about asking these questions.
So I was reading a lot about Basildon Hospital and the problems that they had, and it seemed that there was a very easy, cheap, innovative solution to help dementia patients find their way around the wards, and that was to actually paint some of the walls different colours. So sometimes we think of innovation as hugely costly projects, but sometimes it's quite simple. And the other interesting thing, John, you can comment on this, is that they actually put a new chief executive in who spent time walking the wards and actually turning up to these meetings in the hospital canteen in the morning to hear the staff views and their ideas on things. Is it about funding or is it about leadership, or both?
I don't know where to begin. Innovation in the NHS is very difficult. The huge drive is to maintain the status quo, because anything new that comes along costs more money, and there isn't any more money. So any new techniques, any new drugs, the whole ethos is to try and stop it being promulgated or being rolled out. There are little things which you can do to try and make things more efficient, but it's a question of how you incentivize people. There has to be a greater sense of ownership, not just in the NHS amongst the managers and the doctors and the nurses, but also amongst the patients and the public as to how they use the facilities, what people have to take personal responsibility for it. There has to be much more of a direct connection between the consumer and the providers. People have no concept how much healthcare costs, and somebody else is paying for it anyway, so why should I do anything about it?
So how do we, in order to save the NHS money, how do we incentivise people to take responsibility and maybe take out their own insurance plan?
I think you have to make it have a much clearer relationship between people's behaviour and the potential knock-on effects. We've heard already how there are already tobacco, alcohol taxes make a contribution to society. Obesity, there is no tax on food as such, therefore there's no contribution. So maybe we should look at incentivising people in another way. Maybe we should be giving people tax breaks for maintaining a healthy BMI, maintaining their fitness. There needs to be another way to make people more responsive and to make decisions in their own interests, rather than the concept that it doesn't matter what I do because somebody else will pay for it and sort it out later on.
John, how is the communication working in the area of innovation? I gather from doing my research that there's a big problem of the NHS trusting private companies, and maybe a little bit the other way. Is the dialogue really working to make innovation happen?
In my own job, the only innovation I really come across is from the companies who are making new kit, new drugs, everything else. I haven't experienced any wildly innovative things in my day-to-day NHS practice.
Doug, Aviva, would you say that there is a cultural problem? What sort of areas of innovation are you looking at?
I think we always lump innovation into one word and think about it in one way. I think there's different ways of thinking about innovation. The bit where I don't think there is a problem with it is around the development of new technologies, new techniques, new drugs. So that type of innovation I think we're very comfortable with, and that's the one that we tend to talk about all the time. I think the two big areas we don't progress well enough are innovation around how the care is delivered and how people access care, and I'll just briefly talk in a moment about how we've done something different around that for our customer base. But the really important part is how do you use innovation to enact that behavioural change that we know we need to see around those lifestyle factors that lead to obesity, lead to inactivity, etc., because those are the growing problems for our healthcare systems overall. I think that's the big challenge, and how do we connect people and empower people to develop the right habits to improve those factors.
Excite me about that. How are you going to do it?
Well, I was going to talk a little bit more about how do you change a healthcare system to deliver the outcomes that actually people need when they have something go wrong with them. So what we've done at Aviva is actually change how our customers access musculoskeletal services, for instance. So it used to be a very disjointed journey. It always used to be driven quite a lot by the benefit design of the insurance policy. The simple change that we've made is actually to put in place a care pathway around that, and looking at and tracking and managing the outcomes that we're helping our customers get to. Now, that's a simple thing to describe. It's quite a big change for how the insurance product works, how our contracts with the hospitals and the specialists work, and indeed how the providers of the services work as well. But putting in place that change has improved everything really around that. It's improved people's ability to access it, the speed, the convenience. It's improved the time taken to get better. But equally, it's also managed the costs down previously to what they were as well. And we provide this to our corporate customers, the employers who are funding these healthcare services, where all of those features really add up to making that a much more powerful benefit than it has been before.
Now, Doug, I know that you were originally a GP, and as an ordinary woman in the street, innovation in terms of getting my GP and consultant, if I have a problem, to talk to each other and talk to me. Is that going to be expensive in terms of more doctor time? Is it going to be cheaper? Is it going to happen? Are doctors going to be resistant? You've got your memories of being a GP. What do you think?
Yes, so I was last in practice 15 years ago, which was quite a long time ago. At that time, I introduced telephone surgeries into our practice. Obviously, we used to all speak to patients on the phone around follow-up things and bits we'd agreed. I actually operated and introduced a telephone surgery, which allows you the opportunity to speak to lots of different patients and filter out and help them sort out their problems. And equally then, at the end of that, you could see them face-to-face for those ones that needed to do it. Now that felt quite innovative at the time. I'm still hearing about GP surgeries that don't run telephone services for their patients, and that's really the starting point for all of this. We hear increasingly, of course, about moving on to Skype-enabled consultations, remote medicine, tele-enabled medicine. And I think that's some of the sorts of innovations we do need to see, not necessarily always conducted by the GP as well, because, of course, there's a large number of other highly trained health professionals out there, ranging from nurses to pharmacists, that can provide that sort of service and connect with patients in a very different way.
Derek, you wanted to come in there?
Well, the real innovators tend to be on the west coast of America. Less so, but they do. But if you take Facebook, for instance, it's announced this week that it's going to look at business communication. Well, the natural thing then for is to have a Facebook medicine or health package care. So have we been to talk to them and look to see how we could use their technology rather than trying inventing the wheel? And secondly, there's another rather clever thing's come out. It's a web page, or it's an app called Slack. So you have favourite people that you like to email, and you have favourite people you like to phone. You just put a Slack system in, you put all their numbers and emails, and it's done. You want to send a photo, you just go, you have to go all the people that are in your friendship thing or on Facebook. Now, are you saying that you can't put all your prescriptions in there, or all your x-rays, or it's so easy. We can't, for some reason, we don't like to share. We don't like to take things from other people. Again, I come back to the cultural thing, but they're there. But does the civil service, does the senior civil service that runs the health service, really understand fundamental change? And I don't think they do.
John?
The problem is that, I think the younger generation will embrace digital technology, and I think they will get used to the idea of video consultations or telephone consultations. Benenden, we have a 24/7 GP helpline, which you can speak to a GP who will call you back. That's there. There are other apps coming on. There's Babylon Health, which Ali Pass is launching or has launched, where you can upload all your medical records. You can book a telephone conversation with a specialist. I think the younger generation will undoubtedly get used to that. You can already upload your medical records into Google Health, I believe. People will take greater ownership. It will be more portable. It will be more accessible. That, however, is not going to address the elderly population who perhaps haven't embraced that technology as much, but they are the people who are consuming healthcare in huge quantities. The average spend on an over 70 or 80-year-old, which is the growing population, is 10 times what it is on the people in work. And it's how we incentivize people to take advantage of those sorts of things. A lot of people will pop into the GP for a chat, not because they're necessarily ill, but they want to have a chat to somebody. There's increasing social isolation.
I was going to say, will this technology and innovation in this area, will we get back to, not quite, but almost the sort of mid-Staffordshire idea where the health service doesn't care anymore because you're directed to a machine, you're directed to your phone, and there's nothing to compare with you sitting with a GP if you're a bit upset and they just reach out their hand to you.
I don't think it's a question of people not caring. It's a question of people's expectations and what they want. The more barriers you put in front of people to access healthcare, then the less you will end up having to give. But people will find something which they want to access, and they will be prepared to pay for it. They'll be prepared to work a way around the system somewhere.
So, Doug, would you say then that what you're doing is a little bit unfair because you're going to get lots of interest from a younger audience, and you might not be helping older people with your apps and your technology.
Well, I think the key thing is you need to maintain the right services for all of your different patients, all of your different customers. I think John's absolutely right. The technology-enabled approach to it automatically engages the younger generations much more quickly. The challenge is how do you use that then increased capacity that you generate to make sure you're serving your different segments of population in the right way? I think that has to be the approach.
Do you think, John, that we're focusing too much on technology and innovation without actually getting doctors in the medical profession to hand over some of their power to the patients? And we're slowly coming out of a slightly old-fashioned era where the doctor has all the knowledge and you're supposed to sort of, I'm making this up, but you turn up to your consultation and you sit there and you don't ask questions and you just take your orders from the doctor. Do you think that innovation aside, we need to really work on these communications issues in the health service?
Well, medicine is becoming increasingly consumer-focused. I mean, it's a commodity which people want to access and they're prepared to buy. They have to pay for it, they have to buy it somewhere. I think the role of the doctor is changing. There is a huge amount of information out there which is readily available. Rather than giving people that information, our job is increasingly to guide people through it and to steer people in the right direction and to filter out what is good information and what is bad information.
At this point, before he's even put his cup of coffee down,
hello.
I'd like to introduce Declan. Declan, you introduce yourself to the panel. We're talking about innovation and the private sector, so it's opportune that you've just arrived.
Right. You're implying I'm good commercially and I'm good at innovation. We'll see. My name is Jacqueline Flanagan. I'm the medical director of Moorfields Eye Hospital. I'm an eye surgeon. I've been in medical for 5 years. Prior to that, I was deputy medical director, and I actually spent a lot of my career in Addenbrooke's in Cambridge. And for a period of time, 3 or 4 years, I was medical director of one of the smallest and, dare I say, more challenged trusts in the country, Hinchinbrook Hospital, some years ago. So I have experience of the small District General Hospital, the large, dare I say it, successful teaching hospital, Addenbrooke's, and more recently in Moorfields, which is a somewhat unusual institution, seeing 500,000 patients a year, 50,000 procedures a year on 23 sites, which is, it's a very big institution. One sometimes wonders if it's too big. But having said that, we have grown, we've tightened our processes, we've learned, we'd like to think, to manage quality on 23 sites and get it right a lot of the time. I don't lose as much sleep as I used to do over that, though it's not always a smooth ride. I think it's fair to say all hospitals do a certain amount of satellite or outreach clinics. Moorfields got its first satellite in 1992, and it was a response by my predecessor, but one. He foresaw that he could not expect everybody with an eye problem, a complex eye problem, to come into City Road. It just wasn't feasible or practical, and he foresaw that the Moorfields would die unless it got bigger. And the way to get bigger was to go nearer the patient, which is a time-honoured model, really. You don't wait for your customer to come to you, you go to them. You make it easy, which is why we went to Northwick Park, and then to Ealing, and then to a number of other places. As an institution, we made a surplus of 10 million last year on a turnover of 171 million, which for the NHS is actually quite good. This year won't be as good, but it does suggest that we have got control of our costs and we've got a model that works.
But just before I ask you about funding and raising money for research and this, you tell us about this brand new hospital that's going up. Can I just ask you about other models? I mean, Hinchinbrook, Circle. Mm-hmm. What's the magic about Circle? I mean, how have they managed to do this? What's the secret?
I don't actually work for Circle, so I'm obviously wary of talking about them, but I have visited their hospital in Bath, their first one. I was very impressed with it. They seem to be doing quite a few things well. Though nothing they were actually doing was actually rocket science. They seem to be doing quite a lot of things well, probably slightly more than others were at the time, In Hinchinbrook, they've taken on an enormous challenge, which they have put a lot of effort into. I'm not quite sure whether they've got there yet with Hinchinbrook. They've certainly innovated quite a lot, and time will tell whether they're doing anything really different, or whether they're just adopting best practice from other places, and which is legitimate, and pulling it together.
But simple things like in Bath not having these rather intimidating signs to the radiology department or whatever, and it makes a more sort of human place to be. Do you think that's actually helping people's health? And maybe ultimately, although we can't really scientifically record it, it's actually stopping people getting ill because they had a very good experience in Bath, less stressful being in the hospital, don't have to come back.
Well, the point I would say is that certainly less stress can only be a good thing. Frankly, to switch to staff, if you look after your staff well, if you make sure they are not forced into impossible situations, if they are not driven too hard, if they are supported, if you put a lot of emphasis on how staff interact with each other, how they get the behaviours right, that leads to a much more effective organisation with much less risk of mistakes. The way to make mistakes is to put staff in situations where they're just not organised, feel out of control. And I think in that respect, the right environment is a key part of patient safety and good results. Patients themselves should not be intimidated by a hospital. And one of the problems of a very big hospital, even if it's very comprehensive, it is by its very nature intimidating. So we do have to make sure that when one designs hospitals which are big, and they're big because of the service they have to offer, that one does look at it from the customer's point of view, from the patient's point of view, so they are user friendly.
So is this what you're going to do? And just explain that you're building a brand new hospital, aren't you?
Yes, Moorfields. The current Moorfields has been, the core of it was built in 1896. It was moved out from the centre of the city to what was then, dare I say, an almost greenfield site, just north of Old Street Tube. It has survived 2 world wars, was bombed in one. It is no longer fit for purpose. It's very difficult to work with. I worry about what bit's going to fall down tomorrow. We put a lot of work into keeping it functioning. We need a bigger space to do our core job of providing services to people when they need them. I'll come back to that in a moment. To running the biggest research, the biggest ophthalmic research unit in Europe and probably in the world. Moorfields has a higher impact factor and has more publications than by a factor of 50% than the next biggest North American institution. For some reason, and moving on to that, we have the education pillar. So we have 3 pillars that we need to build a new hospital for. One is service delivery, the service to patients accessible. Secondly is research, and thirdly is education. I would stress that the Institute of Ophthalmology, which is UCL and shares the Moorfields site, is regarded as the most successful medical subspecialty research service in the UK at the moment, which is which is really a reflection of the way the NHS works. It has allowed us to get the critical mass of patients with rare conditions, which attracts good clinicians, which then attracts the small number of people who are good at research, and it's keeping that synergy going. Patients, research scientists, clinical scientists, and educating. That's the key to Moorfields, and is probably the key to a lot of other successful UK medical institutions.
And Declan, I want to ask you, you need funding, don't you, for this new hospital and for research?
Yes.
All the time, like everybody else does. Are you worried about asking the private sector?
I never worry about asking for money. If you don't ask, you don't get. Where Moorfields itself, as anybody in the private sector here today will realise, has a big private setup. We're one of the biggest NHS hospitals with one of the biggest NHS private combinations in the country, along with the Royal Marsden and a few other hospitals. We have always relied on private practice to keep the whole institution viable. And certainly the service from our private practice activities does contribute to our NHS work and to our education. We wouldn't be what we are, I think, without the successful private practice on the site. And that's both for UK patients and from abroad. We wouldn't have been able to develop our Dubai branch without having already run a successful private setup in London.
But you're going to ask patients as well as corporates for money?
Yes, we will do, and we'll be approaching hopefully our large base of patients who hopefully appreciate the care we've given them to support future research and future service delivery. The whole emphasis is on research, and I think it's not the building, it's the purpose of the building. If you put good people in a tent, they'll almost certainly do good work, if they have to. But it's making sure that you're not contributing to the building, you're contributing to what goes on in the building and the effective clinical and research teams that need this building to do their thing.
I'd actually heard that you're all too nice at Moorfields, in that you will never get rid of patients. The doctors are so lovely. You know, as soon as you've had your appointment, you're signed up to another one just in case. Is that a drain? Do you need to sort of change your model and be a bit more ruthless? Or?
Yeah, there is an issue of new patients to review patients, and the NHS has ratios. However, you have to personalise it. If a patient needs 10 appointments, they've got to get them. If they need one, they've got to get them. And we need to work with other providers to make sure that patients don't come to Moorfields unnecessarily if somebody else can do the job just as well and just as safely in a joined-up fashion somewhere else. And if that's an optometrist, that's fine. If it's a GP surgery, that's fine. If it's another provider, fine. I do not like the principle of a monopoly, and I'm much happier in it where there's a certain amount of tension in the system, and there are some other people are saying you could do it this way or that way, where we have to justify the way we do it all the time. Not in a particularly aggressive fashion, but this is how we do it. This patient needs this, and we're sticking to our guns on this. If you have an alternative view, let's hear it, but let's debate it. We're very wary of we're looking for evidence when we're changing. Moving to 23 sites would suggest that we have a track record of decentralising and devolving and working with other providers. If we hadn't moved, I think we could be rightly accused of being a centralising, insular organisation. The fact that we've gone to 20 other places would suggest we are reasonably good at working with local providers and giving patients what they want. I think it's fair to say that most of the Moorfield sites, we're there because we were asked to go there. We're there because there were problems with provision before. And we have practically never gone to a greenfield site and set up something. We've normally had to go and sort out a situation which is unacceptable. And that, I suspect, that may well be the way it always is.
John, can I bring you back in here? I mean, are you green with envy about hearing this new hospital going up? And what about your hospital in Kent? Are you doing things, even without brand new buildings, are you doing fantastic things?
Well, it's interesting because we've got one of the largest cataract providers in the southeast. We're in the independent sector, but we provide it for our members. And that's largely being driven by constraints in the NHS. It is much harder for people to have their cataract surgery now in the NHS, and it's something which we're offering to our members. We're currently rebuilding our own hospital, so it's a £45 million project. Again, we've encountered the same problems. Bennington's been around for over 100 years now. The original hospital site was no longer fit for purpose, so we're having to bring it kicking and screaming into the 21st century. So we're having new theatre suites, we're having new outpatients, we're having new rooms built. All of this is being done from, if you like, from our members' own money. We're not going out to the private sector, we're not relying on state funding. This is all coming from people's own contributions. It's owned by the members for the members. And I think that is a way of a potential way of addressing some of the financial problems which are looming. If we can get people more involved and more have a greater sense of ownership of their own health needs, then I think that can only be good.
Derek, can I get you to make a final comment then? Because it all seems incredibly rosy. I mean, I just can't wait to see this new Moorfields hospital going up, and it seems like there's lots of money swishing around. Do we need any more innovation? Are we actually doing a very good job?
Oh, we always need innovation, otherwise we'd be falling asleep. It's quite an exciting thing to wake up to change, I think.
But I suppose, is it right to concentrate it all in these very huge hubs? Is that the right way to go?
Well, change, listen, this is a massive issue. This is a massive issue, God. The point is, the banking system doesn't work. And therefore, if it's not working, we have to change the banking system. The banking system is moving to a crowdsourcing, crowdfunding world. In 3 years, that would be £100 billion a week coming in and changing. That is a massive change. Why is that? Because the banks have lost their customers. They started having no managers. They started having call centres abroad. They just used us and abused us. And then they actually abused us internationally. And the people are fed up with that. So fundamental, you need seed corn money to start change. And the idea that your health, your hospital trust, anybody on that board would understand fundamental change. I'm sorry, it's just not possible. So don't try and put a crowdsourcing person on there. Start with that disruptive model. That's what's really interesting. And don't start off with another NHS innovation thing or another. Start with what is actually so exciting. And that is what we haven't grasped yet, is this thing is coming through underneath. And I would like, in the same way that Nest has done rather good things, I think there is another kind of NHS model that's partly private, partly public. I call it public equity, not private equity. And I think once we get a public equity fund together, boy, the health service will move, but not within the health service.
And I think that's where Benedict can come in. The role of mutuals in providing healthcare is very much underutilised in this country. If we look across the channel, then far more healthcare is provided by friendly societies and mutuals. And I think because of the funding issues we're going to encounter in the next few years, we have to find a way of getting more money into healthcare. I don't think it's going to come from taxation. It's going to have to be down to individuals to make a greater contribution, to take more responsibility themselves. And I think the mutual model will provide a way to do that. We're not answerable to private investors. We're not answerable to venture capitalists. We're not answerable to shareholders. It's owned by the members for the members.
So it's a sort of back to the past to go forward.
Why not?